you so much for tuning in. Thank you for liking our channel. Let me just check. Right, I think we're good to go. So, this is SmartNursing. Once again, we are here to discuss a few things about nursing. And for those who already know, usually on Sundays, we are on the farm, after church. And so, this is one of those Sundays that we are here live from the farm. As you can see, some maize is in the backyard. Down there, we have some rice and our chicken or poultry. It's over there. All right. So, we are so happy to be here with you once again. And today, we want to talk about acute coronary syndrome, or what we simply call a heart attack. Okay. Well, maybe not all of them can be referred to as heart attack, but then let's talk about acute coronary syndrome. Okay, so when we're talking about acute coronary syndrome, then I want you to understand this by just breaking the words down. Okay, just let the word help you. So, acute means something of a very sudden onset, right? If it's acute, then it's of a very sudden onset. Okay. Then we have coronary. When we're talking about coronary, then we're talking about the heart. Okay. Things that, you know, concerns the heart or the circulation system of the heart, basically. That is what coronary stands for. Then we're talking about a syndrome. So a syndrome is a group of symptoms, that usually are geared towards a particular condition, okay, or a particular disease. It's a group of symptoms. So we have more than two of a symptom, then you can call that a syndrome. All right. Hello, thank you so much for joining. Give us a like if it's your first time. Let me know your name and where you're watching us from. Okay, we are live from Ghana, and this is Smart Nursing. And today we just want to talk about acute coronary syndrome. And then you're the very first person to join our live, and we are so grateful for you. Okay, thank you all guys for joining. Let me know where you're watching us from. Okay, I will be very glad. I'm live from the farm, as you can see, and this is Ghana. It's around 5 p.m. over here. All right, so when we talk about acute coronary syndrome, like I said, it's of an acute onset, which means that it starts very suddenly. Then you have coronary system involved, and then you have syndromes. Okay, so we have three main types of acute coronary syndrome. We have three main types. Now, before we go into the types, we have a criteria that diagnoses acute coronary syndrome. You have to satisfy three things. To be able to diagnose the syndrome, you will have to satisfy three things. Okay. The first one is symptoms. All right. The second is cardiac enzymes. And then the third is what? ECG changes. I'll take that again. You need to have symptoms. All right. You need to have. Hello, Charlotte. Thanks for joining. Where are you watching us from? Okay, so you need to have symptoms. You need to have what we call cardiac enzymes present, and then you need to have ECG changes. These three criteria actually describes or differentiates the types of acute coronary syndrome from the other. All right. So the three main types of acute coronary syndrome are unstable angina. Okay. Then we have NSTEMI, or what we call non-ST elevation myocardial infarction. I mean, it seems like a long word, but it's not really long. Okay. We will dive into it very soon. And then we have ST elevation, MI, or what we call STEMI for short. Okay, and that is the heart attack proper. Hi Charlotte. So NSTEMI is just a type of acute coronary syndrome. Okay, I'll be explaining what that means, or it's a type of a heart attack. Let's take it like that. Okay, right. So for unstable angina, okay, I've been booked. Wow, that sounds good. For what exactly? All right. So for unstable angina, the patient usually complains of chest pain. Hi, Senora. I hardly can read, I think it's Spanish. Thank you for joining. I can't read Spanish, but I'm grateful you're joined. Okay? All right. And I hope you can understand me. So, your patient has a chest pain in unstable angina. In fact, chest pain cuts across all the three types of acute coronary syndrome. All right? You will have a chest pain for all the three types. Okay? That chest pain usually is retrosternal. Okay? That chest pain is retrosternal. When we say retrosternal, it means that the pain is somewhere over here behind the sternum. The patient usually points at a place behind the sternum over here and says that he feels the pain here. Usually, that pain is described as crushing, okay? It's described as pressure. It's described as a discomfort. And that pain can either radiate to your jaw or can radiate to your left arm. Sometimes it can radiate to the back. Okay, I'm live from Ghana, Charlotte. I'm live from Ghana. Where are you watching me from? All right. So that is the pain or the chest pain that usually accompanies acute coronary syndrome. Okay. Now, any pain that is cardiac in nature, okay, any pain that I just described, any pain that is over here, any pain, I think I have it by 1,000, yeah. Any pain that is over here, any pain that is described as crushing, any pain that is described as pressure is called an angina pain. You can have that pain when maybe you're exercising or you're doing an activity that requires the use of, the burning of energy. It requires the use of a lot of energy or a lot of calories. You can feel that pain. Then what it means is that there's some form of pressure on your cardiac system. There's some form of pressure on your heart to actually pump blood around your body, and that gives you that kind of pain. Now, that pain can be stable if it goes away with rest. So, for example, if you're walking and then you feel the chest pain, you sit down and you don't feel any pain, that can be described as a stable angina, or a pain that comes in less than 5 minutes, it goes away by itself. That is a stable angina. Okay, but it becomes an unstable angina if it persists even with rest. All right, it becomes a stable angina if even at rest you still feel the pain in your chest. Okay, if you still feel the pain in your chest even after you're resting, then it becomes an unstable angina. So let me take that again. An unstable angina, which is one of the types of acute coronary syndrome, is when you feel the chest pain, the crushing chest pain, the pressure like chest pain, the discomfort that is in your chest that form of chest tightness that the patient will describe to you. If you feel that kind of pain, the pain radiates to your back, radiates to your chest, or radiates to your left arm, then it doesn't go away with rest. It persists after 5 minutes. Then that type of pain becomes an unstable angina. Now, mind you, I said earlier on that this type of pain, this description of pain, actually cuts across all the types. So, what differentiates a unstable angina from the rest of the ACS conditions? What differentiates them? Now, for unstable angina, you will have that pain without cardiac enzymes and without ECG changes. Okay, you will have that pain without ECG changes, without cardiac enzymes. So usually in unstable angina, you have that crushing chest pain that is persisting after 5 minutes, all right? But there are no cardiac enzymes. Cardiac enzymes are usually done when you complain about that type of chest pain. They take your blood sample, they take it to the lab, and then they are looking for troponins I and T or CKMB. These things are what we call the cardiac enzymes. There are some proteins that are in the cardiac myocytes, okay? They are in the muscles in your heart, and they are actually released when there's an injury or there's a damage to that part of the heart or that muscle. Okay, so in unstable angina, it means that the injury or the insult to the heart, that part of the heart, is not that severe. And so there is no damage in the cardiac and myocytes, okay? There is no damage in the muscles. And so you will not see those cardiac enzymes being released. And also in that same vein, you will not see an ECG change. You will not see any ECG change. Now, mind you, every chest pain has to, ECG has to be done for every chest pain. The dot to ECG time is usually around 30 minutes. Immediately someone walks to an ER or an ED and complains of a chest pain, usually you will get an ECG done within 30 minutes. It is to rule out all these things. Okay, so for unstable angina, usually the damage to your artery, okay, the damage to the coronary system, the part of the coronary system supplying that part of the heart that is damaged, it's not really big. Maybe it's around 40-50%. Usually, you know that in atherosclerosis, that leads to narrowing of your vessels. That is where you will get blood supply being reduced to this part of, the heart, the brain, wherever that artery is supplying, and that is what will lead to the acute coronary syndrome in this case. So in unstable angina, your occlusion is very minimal. It is not big enough, maybe around 40-50%. Okay, so there is no damage, there's no significant damage to that part of the heart. And so that will not give you any cardiac enzymes when you do the labs, and it will also give you any ECG changes. Okay, so usually with unstable angina, you can give your morphine, you can give your oxygen if it's needed. Usually, we advise that, or the teachings are that oxygen is given if only SpO2 is less than 95%. If it's 95 and above, you don't need to give oxygen. Okay, so the acronym MONA or MONABASH, if you want to extend it, is what we use for all the three types of acute coronary syndrome. So M stands for morphine. You can give morphine for pain. Okay, you can give oxygen if you have to. You can give nitroglycerin, that is the N, or GTN. Okay, sublingual GTN. You can give that, and then you give aspirin. Usually, most people do 300 milligrams start of aspirin. Okay, so for unstable angina, this is a pathophysiology, and this is how it comes about. Usually, after doing your nitroglycerin, the patient, you know, becomes okay, the pain goes away. Then, if you take blood samples and there are no, you know, what do you call it, cardiac enzymes, then ECG changes, there are no ECG changes, you have a normal sinus rhythm. Sorry, you conclude that you have an unstable angina. Now, after that, you will just teach your patient on, things that they can control, things that they cannot control. If it's about behavioral changes, you're going to teach your patients about avoiding sedentary lifestyles, okay, doing exercises as often as they can tolerate. All right. Then you can also talk about cessation of smoking if the patient actually admits to smoking. Okay, if the patient is a diabetic, you will encourage the person to continue taking their anti-diabetics. A hypertensive, you encourage the person to take their antihypertensives. If you have some dyslipidemias, then you're going to advise the patient to continue taking their, you know, atorvastatins. They are statins. Okay, so let's talk about the NSTEMI, or what we call the non-ST elevation myocardial infarction. In fact, if you've been following SmartNursing for a while, we spoke about, we did some ECGs, okay? We showed you what a normal sinus rhythm is, what you should expect it to look like. We showed you what, a PQRST, if you take a rhythm, which is like a pulse, a beat, one beat. We show you where the P wave is, what is the Q, the R, the S, the T. We showed you all these things, okay? So what we are concentrating on when we're talking about acute coronary syndrome, or when we're dealing with heart attacks, we're looking at the ST junction. Okay, don't worry yourself, just refer to the video on SmartNursing page where we talk about ECG. All right, refer to the ST part, the junction of the S joining the T, where the S joins the T, or what we call the J point. That is what we are referring to over here. Okay, so in non-ST elevation myocardial infarction, which basically I will tell you once again is just let the name guide you. Just look at the name. It looks long, but what it means is non means no. ST elevation myocardial infarction. So there is no ST elevation. In this type of myocardial infarction, when you take the ECG, you will not see any ST elevation. Okay? When you take the ECG with this one, you will not see any ST elevation. That is simply what it means. But there is a myocardial infarction, so we'll explain that. So in NSTEMI, the patient has this chest pain, just like an unstable angina. Okay. Then you do your lab values, and there are cardiac enzymes. I spoke about troponins I and T, and I spoke about CKMB. Okay, these are the cardiac enzymes that we are looking for. And I said that these enzymes are proteins in the cardiac myocyte. They are proteins in the muscles of the heart. They are released when the heart or that part of the heart gets damaged. Hello, hello, hi, you're welcome. Give this video a like, okay? Brooke Corey, I hope I got the name right. Where are you watching me from? I'm live from Ghana. All right, so what was I saying? Yes, so I was talking about cardiac enzymes, okay? So these enzymes are proteins that are inside the cardiac myocyte in the muscles of the heart. All right, so when it gets damaged, they are released into the blood system. They are released into the circulation. And so that is what the lab will pick from the sample. So your blood sample will be taken and sent to the lab. In emergencies, we are looking at the troponins, the I and the T. The reason is that these cardiac enzymes peak very fast. Within 3 to 4 hours, the troponins I and T are already all over the blood system. Okay, but then they peak around 12 hours and then they go down within a day or two. So in acute infarction, when you want to confirm whether there's any acute myocardial infarction ongoing or a very first new one ongoing, your concentration is on your troponins I and T. Okay. Now, when you want to see whether it's a reinfarction is maybe some days ago, some years ago, or months ago, this patient had a a myocardial infarction. The patient has suffered a heart attack before. Maybe it's a new one. Then you are going to pay attention to the CKMB, okay? Because the CKMBs, they take some time to, come around, but then they don't go away easily. Okay, they don't go away easily. So if you see a CKMB, then it means that it probably an infection that has happened a long time ago, and then you are getting a new one on top, or it hasn't gone away. Okay, so that is the main difference between troponins I and T and then CKMB. So usually in acute infection, we are looking at troponins I and T. Okay, there are values, and so when you do your lab and then the results come back and it's more than that, then it means that your patient has an acute infection ongoing. All right. So I was talking about NSTEMI, right? So for NSTEMI, there is chest pain, there are cardiac enzymes present, or there are positive cardiac enzymes, but there are no ECG changes. You will take the ECG and it is very normal. Meanwhile, your patient has a chest pain and then cardiac enzymes are positive. So that is why it is called non-ST elevation myocardial infarction. There is no ST elevation on the ECG, but there's an infarction because your cardiac enzymes are positive. All right. So what have we been saying so far? I have been saying that we have, you know, unstable angina, we have NSTEMI or non-ST elevation myocardial infarction, and these are two of the three types of acute coronary syndrome or heart attacks that we know. Okay, so in managing NSTEMI is just the same as the unstable angina. You're going to do your morphine, you're going to do oxygen if the SpO2 is less than 95. Okay, then you're going to do nitroglycerin, and then you're going to do aspirin. Then after that, you might do some beta blockers. Okay, you can do some atorvastatin if the patient has dyslipidemia. You will do anti-diabetics, you will do anti-hypertensive if your patient is also diabetic and also hypertensive. Okay, then you're going to educate your patients on behavioral changes, lifestyle changes, exercise, rest, sleep, good diet. Okay, cessation of smoking. So the management is basically the same, but the difference is what I'm trying to give you here. So when we come, and so in NSTEMI also, I said earlier that in unstable angina or the very mild type, so you can actually say that unstable angina is a milder form, then it becomes a bit severe when it's an NSTEMI, and the worst part is the STEMI. Okay, so in NSTEMI, the damage or the blockade of the artery is usually between 60 to 80 thereabouts. Whilst in unstable angina, you're having you're having a blockade, you're having a damage, or you're having a reduced supply to the heart or the myocardial parts involved, like about 40 to 50%. But in STEMI, your damage is usually between 60 and 80. Okay, so how about STEMI? STEMI is the worst of all. That is the ST elevation myocardial infarction. So in this type of myocardial infarction, we have ECG changes with elevation of the ST segment. Okay, and then you will have cardiac enzymes positive. You will have your troponins INT positive. And if it's a reinfection or it's an old one, or the person has had one before, then you also have your CKMB also very, very positive. Then that chest pain that is crushing, that is pressure like, that chest tightness will also be there. So, STEMI, I beg your pardon, satisfy all these three, you know, things. Chest pain is there, cardiac enzymes are positive, and then there are ECG changes. That is your ST elevation. Okay, I'll always say again that you go back to the video where we talk about ECGs, and I showed you what a normal sinus rhythm is. I showed you what the isoelectric line is, okay, and that is usually our reference. So you will see that in STEMI, the ST segment, the junction where the S wave and the T wave meet will be above the isoelectric line. And that is what we are referring to as ECG changes. Okay. Now, apart from that, you might have T wave inversions at some places. Okay. Now, in order to diagnose, STEMI, in order to have a complete confirmation that this is a myocardial infarction, your ST elevation has to follow some pattern. It has to follow some pattern. I also did a video when I talk about the leads and where they point to. Okay, so every lead on the ECG paper talks about a particular part of the heart. So there are some group of leads that are pointing to the anterior part of the heart. There are other groups that are pointing to the lateral side. Others are pointing to the anterior, others are pointing to the septum, okay, and others are actually pointing to the back, okay, posterior part of the heart. So if you are having an ST elevation, for it to be that, or for it to be pointing to myocardial infarction, then if it's in lead 2, you must see it in lead 1 and AVL, okay, because those groups look at the lateral side of the heart. Okay, so let me take that again. If you're seeing ST elevation in one lead that points at, say, the lateral part of the heart, you have to look at the rest of the leads that are actually pointing to the lateral part of the heart together and see if the ST elevation is consistent in all these leads. That is not all. After that, you will have to look for reciprocal changes. Okay, so over here, we use an acronym to guide us. We have what we call the PILES, the PIALES. P stands for posterior, I for inferior, A for anterior, L for lateral, and then we have E and S. S is for the septum. Okay, what it means is that, if you're seeing an ST elevation in the posterior leads, you must see a depression, okay, in the inferior leads. If you're seeing an ST elevation in the inferior leads, you must see a depression in the lateral leads. Okay, so it goes on and on like that. You follow the acronym, and if you're seeing an elevation somewhere, look for reciprocal changes in the opposite leads. All right, if you see that, then you can, confidently say that this is a myocardial infarction, because ST elevation can be anything. All right, that is why ECGs are not diagnosed in isolation. You need to put all other things in context, like your, symptoms, and then also your cardiac enzymes. ST elevation could be a PE. It could be um what, a pericarditis. Okay, you have a global ST elevation. That is an ST elevation in all the leads on the ECG paper, the 12 lead, everything is elevated. It could be a pericarditis. So you need to pay attention to your symptoms, and you need to pay attention to your cardiac enzymes, and you also need to pay attention to whether or not the ST elevation is consistent with all the congruent leads. All right, and then also you need to look at the opposite to see whether or not there's any um, reciprocal changes over there. Now, for STEMI, reperfusion is very, very key. Okay, if it's a myocardial infarction, then you will need a surgical intervention ASAP. Now, so in the hospitals where they were developed and they actually do the stenting, or they do what we call PCI, percutaneous coronary intervention. Okay, it's a very timely procedure that is done to actually stent, the occlusion to that part of the heart that is affected, in order to redeem the heart. Now, what is happening in STEMI, okay, complete myocardial infarction, which is a heart attack, like complete heart attack, is that there is complete occlusion of the artery, usually between 90 to 100%. That part of the heart is not receiving any blood supply at all. There is no blood supply whatsoever going to that part of the heart. And so what is going to happen? First, there is going to be reduce of oxygen to the place. The heart muscle will die. And it is because they die, that is why they release these enzymes into the bloodstream. All right. So when it's dying, it is dying. And the heart is actually supposed to pump blood to the rest of the body. So if your heart is not working, you can imagine all other organs will shut down. And that is why myocardial infarction, or the STEMI, the highest one, is very, very crucial. And so in facilities where they quickly go in, do a reperfusion, intervene, stents the narrowing that is over there, try to do a reperfusion so that other, arteries around, or the collateral arteries around, can actually come and supply that part of the heart. See if they can revive it. Okay, so the patient teachings are basically the same as that for, you know, um, unstable angina, that for non-ST elevation myocardial infarction. Okay, now there is one other key thing that I will want us to take home, is that not everybody will present to you with a chest pain. Chest pain is key because chest pain cuts across all the three types of acute coronary syndrome or heart attack, right? But then, not every patient will present with chest pain, especially in women and then in the elderly. Some don't come with chest pain. Somebody will come with something like an abdominal pain. Okay, they do not present with chest pain. Not everybody will present with chest pain. So your suspicion has to be very high when it comes to these things like this. I remember seeing a patient who actually came, was vomiting, and was having abdominal pain. All right. At the end of the day, cardiac enzymes were positive. We actually had another patient who kept complaining of the arm. This patient never had a history of chest pain even prior to the pain in the arm. She kept complaining about the arm, kept swinging the arm up and down and shouting her arm. And we did the cardiac enzymes and it was positive. ECG, however, was negative. ECG, there were no ECG changes. So obviously, oh my goodness, I think that, just a minute, give me a minute. All right. I hope you can hear me now. So sorry about that. I didn't realize whether or not my audio was still up. I didn't know if I was audible enough, was I? Because I just realized that my mic was off. So sorry, so sorry. But let me know if you can still hear me. If you're here and you can still hear me, can you say hi? Can you say something? Oh my goodness. I didn't realize that I had gone off. I'll be very glad if someone could let me know if they can hear me. Okay. So this has been SmartNursing, and today we were talking about acute coronary syndrome or heart attack, and then we were trying to differentiate and describe what they are. We mentioned that we have three types. We mentioned that um, the criteria that actually diagnoses these things are, first of all, there has to be a chest pain. Second of all, there has to be cardiac enzymes, okay, present. And then there have to be ECG changes, okay. And then we mentioned that the three types are unstable angina, acute coronary syndrome, and then we have, sorry, sorry, the three types are unstable angina, STEMI, and STEMI. Okay. And we said that chest pain cuts across all the three. The chest pain has to be crushing, it has to be pressure like, it has to be, tightening. Okay, some people describe it as chest tightening. All right. And so we said that that chest pain cuts across all the three types of acute coronary syndrome. Now, the difference here is then the cardiac enzymes very present or not, and then whether or not there are ECG changes. Okay. So for NSTEMI, we said that you will have cardiac enzymes being positive, but you will not have any ECG changes. That is why it is a non-ST elevation myocardial infarction. And I always refer us to go back and watch the video where we talked about, you know, sinus reading. We spoke about ECG. We spoke about all the waves describing what they mean and what they stand for. Okay, that is when you will understand the ST elevation, or that point called the ST segment. Okay, you will understand that better when you go back to watch that video. All right, and then we continue to say that in STEMI, the chest pain is there, cardiac enzymes are there, and then there are ECG changes. We further explain that ST elevation can be anything. So for you to differentiate it, or for you to know for sure that it is myocardial infarction, then you need to have reciprocal changes, okay, in the opposite lead. And then you also need to have it being elevated in all the congruent leads. And congruent leads here are the group of leads that point to a particular part of the heart. So if it's the inferior part, all leads that look at the inferior part of the heart must be elevated. All right. If it's the lateral part, all leads that look at the lateral part of the heart must be elevated. Then you need to look at the opposite leads for reciprocal changes, and that is why I gave you the acronym PAILS. Okay, PIALS. Forgive me. So when you look at the posterior, go back and see the inferior to see if there are any reciprocal changes. Okay, my name is Ness Evie, and this has been SmartNursing. Okay, for those of you who have been following us for a while, you already know that on Sundays we are on the farm. Okay, and I showed you, all right, that we have some maize in the background and there's some rice down there. The fowls, the goats, they are all over there. So usually we come here on Sundays and we're usually live from the farm on Sundays. Okay, my name is Nurse Evie. I'm an emergency nurse specialist from Ghana, and I've been doing nursing for over a decade. Okay, and so this is where we are. Now, I would like to know if anybody has any questions for me. Are there any questions? Anything that you want me to clarify? Anything? Do you know anything about heart attack that we haven't mentioned yet? You want to share something with us or you want to ask a question? Kindly go ahead. Okay, we are we are listening. Who is around? Do you have any questions about heart attack? Okay, is there anything that you want me to throw some light on? I will, you know, gladly add my 2 cents to it. Now, over here in Ghana, it's almost 6 p.m., so you can see the weather is darkening around. So, any moment from now, we should be bringing this session to an end. But then I will really like to know if you have any questions for me. All right. Are there any questions about heart attack, about acute coronary syndrome? Do you have any question about the types? Okay, the unstable angina, the NSTEMI, the STEMI. Is there anything that you will want me to throw some light on? I'll try my very best to do that. Hi Charlotte, are you still here? Manuel was here some time ago. Brook Brookcore Brookcore